A physician I know just used ChatGPT to generate differential diagnosis. The AI confidentially listed 5 possibilities and actually buried the real diagnosis at the bottom because the prompt was missing one critical detail. Prompt engineering is now a medical competency. And here is how you do it right. Hello everyone, my name is Roupen Odabashian. I'm an oncologist and I'm the founder of MeDucation AI. This video is part 3 in the AMA AI Literacy series. This is the most immediately practical video in the entire curriculum because prompt engineering is the skill of crafting inputs to an AI system or a large language model to produce reliable, useful clinical outputs. The AMA's Tier 1 competency framework lists this as a foundational skill, and let me show you how to build it. But before going deep, I want to highlight that this applies if you are dealing with general large language models, and by that I mean ChatGPT from OpenAI, Claude from Anthropic, Gemini from Google, Grok from XAI. These are not medical, clinical decision support tools. These are general large language models. The same does not apply when you are dealing with clinical decision support tools, and currently available ones are Doximity GPT from Doximity, as well as Open Evidence. Let's dive in. Why prompt engineering matters in clinical AI? Here is the core principle. The quality of AI output is directly determined by the quality of your input. Garbage in, garbage out. This is not cliche, it's a law and it's proven in literature. Every time you start talking to AI, the AI will assume that the questions that you're asking are asked by the average person. The AI will not know that you're a physician. AI will not know what you're asking for. When you query a large language model in a vague language, you get a vague answer. However, when you provide a context, this is very important, when you provide constraints, when you provide a specific framework, you get something actionable. Bad prompt. For example, what caused a chest pain? Good prompt is a 45-year-old male, diabetic, smoker, with acute substernal chest pain, radiating to the left arm, diaphoretic, generate a differential diagnosis with reasoning. The difference is enormous. The first prompt gives you a textbook list. The second prompt gives you a clinical reasoning differential that fit the context of this patient. But here is where it gets interesting for medicine specifically. Unlike Google search, an LLM will always give you an answer. It never says, I don't have enough information. If your prompt is ambiguous, the AI fills in the gap with assumptions, and those assumptions might be wrong. And that's why the AMA identified that this is a Tier 1 competency. It's not optional. It's the bare minimum to safe use of AI. Let's take a case, and let's talk about the different ways of prompt engineering. Now, let's talk about the principles of prompting. The AMA mentions some principles, but I want to add some extra examples and ways of prompting LLMs because I found them useful in my day-to-day life. So let's start by a case. Let's say you have a 67-year-old female, let's say you are an internist, and she presents with 3 weeks of fatigue, new shortness of breath, and she walks upstairs in her own house. She gets more short of breath. 5 years out of breast cancer, so she's in remission right now. She's still on tamoxifen though. She used to smoke in the past, she doesn't smoke currently, and her sister had a clot in her leg in her 50s. The patient looks fine, her exam is fine. The only thing off is her heart rate, which is around like 102. Now this patient tells you that she's been just working a lot and she's stressed. Let's take this patient, let's run it through different prompts and see how the AI will generate answers. First of all, if you go to any large language model like ChatGPT or Claude and you ask a question, what causes a fatigue in 67-year-old female? The AI will give you a textbook list: anemia, hypothyroidism, depression, sleep apnea, deconditioning, 20 things. There is no ranking, no reasoning. Now, let's define a role. Let's tell the AI you are a board-certified internist evaluating a new patient in the clinic. Same patient, but the output is going to shift. The AI will shift into very different output mode, and it start thinking about the pre-test probability. It start thinking the way you think. You just told the model which pattern in its training data to weigh. A board-certified internist doesn't reason like a general encyclopedia. The same applies to an AI. The second important technique is to provide clinical context. This is very important. Now, you give more context to the large language model. You say, 67-year-old female, she's been experiencing fatigue and new exertional shortness of breath. She has breast cancer in remission and she's on tamoxifen. She's a former smoker. She has a family history of venous thromboembolism. Her heart rate is 102. Otherwise, her exam is unremarkable. If you compare now the results to the previous results that we generated, you will notice there is a huge difference. You will notice now PE is very high on the differential diagnosis. You can even improve this further by specifying the output format. How do you want the output to be? Generic outputs are usually hard to use. Some people like to have an output format in a table. Some people like to have an output format in a narrative way. So you can tell the AI, give me a ranked differential with pretest probability for each and the recommended initial workup. Suddenly, you have something that you can actually act on. Ranked, reason, and there is the workup too. The AI gives you the same clinical thinking, but now it's structured for the situation you are actually in. I have to add a comment here, and this is my personal intake, is now people will say, oh, AI is replacing physicians. Well, I don't think that's going to happen. Most of the AI tools right now, they are processing text. Some of them might be able to process images, but they are still away from reading chest X-ray or a CT scan or looking at the patients. What makes my approach different, and I use this AI tool in my clinical decision support every single day, is when I look at the patient, I have a gut feeling if they are sick or not. And this is something that developed over the years and from seeing tons of patients and feeling when it's appropriate to order an investigation and when not. The AI will list all the investigations that should be ordered or could be ordered in this case. But the question is, should I order all of them or should I start by one followed by the next, depending on the pretest probability, how the patient feels like? So all these things are very important. The fourth important principle is setting constraints and boundaries. And this is important, but not in every specific situation, especially if you're using like Doximity GPT, Open Evidence. I think Ambas now, they have their own clinical decision support tool, and there are so many clinical decision support tools. Doximity GPT allows you to choose where to focus or which journals to focus when it comes to references. However, you cannot do that, I think, in other clinical decision support tools. But if you're using ChatGPT or using Claude or using Gemini, it's important to tell the AI that you want specific references, for example, like the chest guidelines only, or flag recommendations that are based on expert opinion, and you want output that is based on very strong recommendations. The output, again, is going to look different. The fifth important principle is it's very important to iterate and verify. Most clinicians take the first AI output and walk out of the room. Please do not. AI tools are just like carving tools. You can't like just grab a hammer and go and try to create a nice sculpture from a piece of rock. You have to work right, a bit on the left, a bit on the top, a bit on the bottom. You have to improve this piece of rock and use your tools to create the output that you want. The same applies when it comes to AI tools. You cannot ask once and think that you will have the right answer. The most dangerous is to get frustrated and or take the first answer and run away. You have sometimes to use these tools as a thinking partner. There are also other important techniques for prompting I want to talk about, and these are outside of the AMA prompting techniques. One is few-shot prompting. This is important because when we give an AI an example how we want the output to look like, the AI will try to mimic it. And if we give multiple examples, so this is called few-shot prompting, and if we give one example, this is one-shot prompting, and if we give no examples, this is zero-shot prompting. And this is very useful to make sure that the output of the AI matches your desires. This is something you use in research, and I found it very helpful. Let me give you an example. So let's say you are an oncologist, and you're trying to build a comparison table of immune checkpoint inhibitor trials in non-small cell lung cancer. You have 30 abstracts. You need to extract the same data fields from every one of them into the same format. So if you do zero-shot prompting, you go to an LLM, you say, extract the key trial data from these abstracts. And then the output usually is useless. The AI will pick whatever it thinks it's interesting, format it however it wants, and then the next abstract will look completely different stuff. But if we do it with a few-shot prompting, you say like, I'm building comparison table of immune checkpoint inhibitor trials in non-small cell lung cancer. Here are 2 examples of output I want. Example 1, trial Keynote 024, phase 3, the number 305, the population, first-line metastatic non-small cell lung cancer, PD-L1 more than 50%, the intervention, pembrolizumab versus platinum-based chemotherapy, primary endpoint, PFS, results, PFS 10.3 months versus 6 months, and so on. So we'll notice that with this example, if you provide more abstracts, the output is going to be different. And this is called single-shot prompting. This is for a specific or a simple example, I would say, but you can create multiple outputs and multiple edge cases where, let's say, a specific abstract doesn't have the key output or the key data points that you want. You can give also an example on that, and then a specific abstract or another abstract is a different study design. For example, you might give the AI different examples on different study types, how to extract or what kind of data to extract from phase 3 trial versus what kind of data to extract from a systematic review. When you give examples, the output of the AI will be match the examples that you're given. So this is an example of few-shot and one-shot prompting. Now let's talk about the dangers of bad prompting. Bad prompts create 3 specific risks in medicine. 1, hallucination amplification. Vague prompts give the AI more room to fabricate. The less constrained your prompt is, the more likely the AI will fill gaps with plausible but false information. 2, there is also the anchoring bias transfer. If you lead the AI with your suspected diagnosis in the prompt, you will get confirmation bias in the output. Remember, lots of these tools, or many of these tools, try to please you. They are getting better right now, but in general, these tools try to please you, try to be friendly, try to be nice, because these companies eventually want tools to serve their customers. So the AI is not immune to anchoring. Actually, you might cause anchoring in the AI if you don't pay attention to how you prompt it. And then false confidence. AI will always sound confident. A poorly engineered prompt doesn't trigger any uncertainty flags. The output will read like an authoritative recommendation, even when it's built on assumptions from an incomplete prompt. So AI will always sound confident. And I can give you an example from my own research. We run multiple choice questions on different AI tools, and we always ask the AI to give a confidence score, how much the AI was confident in its own answer. And the answer always, regardless of the AI was right or wrong, was around 0.85 to 0.9. Prompt engineering is the most immediate actionable AI competency you can build today. You have to define the role, you have to provide context, you have to specify the format of the output, you have to set constraints, and you should always verify. And you can even improve the output by giving one or multiple examples. If you remember nothing else from this video, remember this. Treat AI output like consultants' recommendations, not like a lab result. It requires your clinical judgment to interpret. Next up is video number 4. We're covering patient privacy, data security, and HIPAA in the age of AI. Because everything we just discussed is about the prompting, none of it matters if you are putting patient data into tools that aren't secure. See you in the next video.